Hello, good morning. We're so excited for you guys to be here for our talk on exercise and body composition. We have really amazing speakers for you. And my name is Allison Bustos. I work with both adults and pediatric patients at the University of Kansas Health System. I'm one of the dietitians. We just got another one, very exciting. Thank you for coming. Hope you enjoy it.
Hi there, and I'm Lauren Mitchell. I'm a physical therapist and very excited to have this co-session together for us to work on our collaboration. It was great to work with Allison. We unfortunately don't have our introductory slides, so I don't have the list of all of our speakers, but we have a rock star group of speakers for us today. What we're gonna do for the format, since body composition is the major theme and everybody is touching on body composition in one way or another, instead of having each speaker do their presentation and then ask questions, we're gonna go through all the presentations and then do a panel of questions at the end. So as you're going, please feel free to submit your questions using the app. If you have someone in particular that you wanna make sure they are the one that answers it, go ahead and put that in there. Otherwise, we'll run through everything, bring them all up on stage, and really have a group collaborative conversation at the end for the questions. But other than that, I am going to, let me get our first slides up here and invite Shannon up on the stage. Is it not? There we go.
Good morning, everyone. I'm Shannon Stamper. I'm from Boise, Idaho, and we're gonna do a lit review for you today. Maybe. It's not moving.
Oh, try that like arrow button.
I have no disclosures. Okay, so our objectives today, we're going to identify the importance of researching body composition in those with CF, so kind of why we're here. Then we're going to review the research on body composition since last year's NACFC. And I could have missed some articles, but I did not leave out any intentionally, and it will not include any that have been published in the last month or so. And then we're going to compare the findings of the studies that monitor body composition before and after modulator therapy specifically. So our agenda, kind of why we care about this topic, why we're here. We're gonna go through some articles in the past year, and then we'll go over the ETI specific articles and then a summary. I have some abbreviations here. Most of you should know these: FEV1, lung function, BIA, bioelectrical impedance analysis. So that's one way we measure body composition. And then the FM and FFM, fat mass and fat-free mass. And if you don't know what ETI is, ask a friend. So why should we care about body composition? So top left, can you see my little, there we go. So top left, BMI. So historically, the globally accepted measure for assessing nutritional status in CF. However, using BMI alone can overlook normal weight obesity, also malnutrition, and fat-free mass depletion. Fat-free mass depletion, or fat-free mass, is more positively correlated with lung function compared to BMI. And lung function is negatively correlated with body fat in CF, at least in adults. BIA, the results are comparable to DEXA. So they've done studies. DEXA is considered the gold standard way to measure body composition, but the BIA studies are comparable. All right, so over the last year, actually, I want to go back. So the number in the top by the title, that's the reference number. So once you get these slides, that's the reference number in the back. I'm going to be going over 22 studies in 17 minutes, so I will be going fast. So muscle mass in adults. So 17, they were randomly assigned to either a high intensity interval training or moderate intensity continuous training for 4 weeks. So there were no changes in body composition found, but they were not compared to inactive patients, and maybe we would have seen a difference if the study would have been longer. It was only 4 weeks long. What about active kids, though? So this was a larger study, 109. 21%, only 21% were actively engaged in physical activity, and 6 of those 23 kids had severe CF. 79%, so the majority, were not active, and 38 out of those 86 kids had severe CF. So whether they were inactive because they had severe CF, or the 6 kids were less severe because they were active, we can't really tell that. And hypodynamic just means a decrease in strength or power. So the kids with CF who are active on a regular basis have less pronounced protein deficiency compared with less active children. All right, so CFRD 20 started on what's called a sensor augmented pump, which is a insulin pump that is combined with a continuous glucose monitor. And then 26 opted to just stay on insulin therapy. This was a 2-year-long study. And what they found was that insulin therapy optimization with the sensor augmented pump resulted in significant improvement in glycemic control, which was associated in an increase in fat-free mass, which is pretty cool. So fat-free mass does not equal muscle mass, but it does include muscle mass. Okay, so during an exacerbation, so this is only an N of 11, so keep that in mind, but they measured indirect calorimetry and BIA 3 times. So right after starting antibiotics, right after stopping antibiotics, and about 6 weeks after. They didn't find any significant within-person changes, but the BMI was positively correlated with fat mass percent, fat mass, and lung function. The BMI was negatively correlated with fat-free mass and EPI. But what they do recommend is, so the predictive equation for energy needs, they found that it consistently underestimated their needs in both when they were sick and well. So what they recommend is using 110 to 130% of non-CF needs compared to the currently recommended 110 to 200%. All right, so kids during an exacerbation. They measured BIA, DEXA, and hand grip strength on day 2 and day of discharge. So 5 of these patients had normal weight obesity, and 3 of them were actually underweight with a body fat percentage in the top tertile. The admission BMI and body composition were positively but not significantly correlated with lung function. The average weight gain during hospitalization was just under 1 kilo, and most of it was fat. Their muscle mass was unchanged, and their hand grip strength was unchanged. So their recommendations, body composition testing should be included in CF care guidelines. I think most of us agree with that by now in some way or form. And focusing on improving skeletal muscle mass and strength while limiting fat mass has the potential to improve short and long-term clinical outcomes. And more research is needed in CF for those with sarcopenia and high body fat percent. All right, so changes over time. This was a 13-year study, so a pretty long study. It was all in peds, and they used DEXA scans. Before I review the results of this one, I do want to point out the difference between fat mass and fat mass index. So the fat mass index you can get by doing fat mass divided by the height in meters squared, and it's just kind of how they fall on that range. It's kind of like Z-scores-ish. And then this will come up a little bit later, the fat-free mass malnutrition. So a fat-free mass index of these, and these are, the bottom part is for adults. So as patients aged, their fat-free mass index increased and their BMI and fat mass index decreased. So all 3 measures were lower than non-CF controls. Fat mass index Z-score had no correlation with FEV1. So that's the opposite of kind of what we found in the adult study. And both fat-free mass index and BMI had a positive but limited strength association with lung function. Okay, lung transplant. So 83 lung transplant participants. This was a 15-year study, so again, a pretty long one. Median time from CT to transplant was 122 days, so a little bit. So The median thoracic skeletal muscle index was higher in men than women. And you can see those numbers right there. Men is on the left. The mean healthy thoracic skeletal muscle index is quite a bit higher, you can see. However, that is the median versus the mean that they quoted in the article. So we can't directly compare those. But there was a significant association between thoracic skeletal muscle index and pre-transplant lung function. So a higher skeletal muscle index was associated with higher lung function. They did not find an association with pre-transplant thoracic skeletal muscle index and death following lung transplant, days to extubation, or their hospital or ICU length of stay. Okay, metabolic markers. This is all in adults. So only 39% of these patients were classified as overweight or obese based on their BMI. However, 81% of the patients had a body fat percent above the recommended range. So 100% of those with high total cholesterol, high LDL, and also those with high blood pressure also had a high or very high percent body fat. So this is not reporting that 100% of those with high cholesterol, blood pressure were overweight. Overweight and high body fat percent are completely different. You can be underweight or a normal weight and still have a high body fat percent, or you can be classified as obese but have a low body fat percent. Muscle and bone. Okay, so this is a pediatric study with a bunch of controls. So no surprise, the controls were heavier and taller than those with CF. And I thought it was interesting that 0% of the controls had a fracture history, while 24% of those with CF had a fracture history. Bone deficits were more apparent in inactive kids. And there was a characteristic bone deficit that they found develops with age in those with CF. And the primary cause was impaired accrual of cortical bone. So it's not that they're losing it, it's just they're not accruing it if they're inactive. So muscle function impacts bone. Okay, a lot of people were asking last year after the body composition talk, I want to start doing body composition, but how long does it take? Their visits are already so long, so I studied it. So in pediatrics, it's about 11 and a half minutes. Adults was a little bit quicker. Initially, so their first body comp test took about 13 minutes and a follow-up was only about 8.6 minutes. With an average total adding about 10 minutes to their clinic visit. So not too bad. Okay, body composition before modulator therapy. So they specified targeted therapy. It doesn't say whether that's ETI or all modulators, but there was a high development of fat-free mass in males, and the females had a high development of fat mass. So there was a high relationship between BMI and fat mass. However, in those less than the 50th percentile, so this is in peds, and those in the 50th percentile, we have historically considered underweight. One child was actually diagnosed with obesity, and 2 children were diagnosed with overweight based on their fat mass percents. Okay, what about after modulator therapy? You're not supposed to be able to read this. You can read it next week when I send it to you, but this is just to point out these are all the studies that I found in the last year that report on ETI therapy and body composition. So these 3 studies show that the fat mass gains were more than the fat-free mass gains, but 5 of the studies reported that the fat-free mass gains were higher. Okay, so I do want to get into this. Study number 7. It reports data separately for those that are homozygous versus heterozygous F508. So in those that are F508 del times 2, the fat mass gains, if you can look at 6 months, the fat mass gains were higher than the fat-free mass gains by quite a bit. But at 12 months, if you go 12 months out after starting ETI, the fat-free mass gains were much higher and they actually lost fat mass. So overall, the fat-free mass gains were higher. Same story in F508 del times 1. After 6 months, more fat mass gains, but after a year, they had more fat-free mass gains. So, summary of this. So, fat mass and weight gains slowed after 6 months. Their fat-free mass increased after 6 months. But it's important to point out that there was an intervention at 6 months, which included a personalized dietary intervention and increased physical activity. So whether that's just the ETI that kind of tapers off after 6 months, or it was the intervention, I think the intervention is important. There was more overall weight gain in the F508 del times 1 than 2. All right, study number 11. So this is their baseline data before they started ETI. So 43% of these adults were underweight, meaning more than half of them were classified as being normal or overweight. So despite being normal or overweight, 91% of these patients qualified for fat-free mass malnutrition. It was higher in females. The numbers at the bottom, 14 and 11. And then the 6-month data. So went from 43 to 39% being underweight. So it did decrease a little bit, but the fat-free mass index scores did not change all that much. And if you can recall, so those numbers at the bottom, those are the cutoffs for fat-free mass malnutrition, and the average scores were well below that. Okay, so. All right, so this is a busy slide, but we did talk about a lot, and sorry I've been talking so fast, but it was necessary. So high body fat percent, not necessarily high body weight, increases the risk for high or worse metabolic markers. And muscle status impacts bone early in life. Let's see if there we go, okay. With exacerbations, more research is needed in CF for those with sarcopenia and high body fat percent. In transplant, thoracic skeletal muscle index does not impact post-transplant outcomes, which actually surprised me. CFRD, improvements in glucose control led to increased fat-free mass, which is pretty cool. Exercise, inactive kids have a higher rate of protein deficiency and bone accrual. And then modulators. So the modulator studies varied a lot based on the time frame, the age, and the sample size. But there was a high percentage of those with CF who had low fat-free mass and high fat mass percents. And we found that diet and exercise interventions can be beneficial. And these are my references.
Okay, thank you, Shannon. That was really impressive and well done within time. So the people want your slides are the questions that we're getting. Okay, next I'm going to invite Diane Lindsay-Alder from Boston Children's up. She's a dietitian, and she is going to walk us through the how-to of body composition testing.
I think I'm good. Good morning, everybody. So I'm going to discuss methods of body composition measurement and the interpretation of the results. Oops. Oh, here, okay. There are no relationships to disclose or related to this presentation. So here's just a visual of some of the devices that are used to measure body composition. On the left is the InBody S10, which is what I use at my center, DEXA machine, tricep skin fold, ultrasound, underwater weighing, and a bod pod, just to give you an idea of what all these devices look like. So I made a chart of all the many different methods of body composition. I'll go through most of them with you, and then I'm going to dig deeper into a few of them and then further slides. So hydrostatic underwater weighing measures body density through water displaced. So the patient must exhale completely and be submerged. It's considered a gold standard, but subjects can have minimal clothing. It's uncomfortable, and it does measure fat mass and lean body mass, but obviously it's not very practical. The second one would be air displacement plus thermography, which is the BOD pod or the P pod. And those measure body volume by measuring changes in pressure in a chamber. Fat has a lower density than fat-free mass, so by comparing the density of the person's body to known densities of fat and fat-free mass and can determine the amount of fat and fat-free mass in the individual's body, that's a very highly accurate way to measure as well. However, that is a very expensive and large machine to buy, and they run around $32,000, so they're pretty expensive. I'm going to skip over DEXA just because I'm going to talk about that more in depth, and also the BIA, the bioelectrical impedance analysis, but I'll talk about CT scans that can be used to measure body composition, particularly if you're assessing the distribution of fat and lean tissue within the body. CT scans are known for their ability to provide detailed cross-sectional images, and they can be adapted for body composition analysis through specialized protocols and software. Again, those aren't as ideal because you have more radiation exposure and there's a higher cost. And then ultrasound can also be used to measure body composition, particularly in assessing subcutaneous fat thickness and muscle thickness in various parts of the body. And our center is part of the STRONG study, so we're going to be including ultrasound measures in our study. And then MRIs can also be used to measure body composition, including the assessment of fat and lean tissue distribution within the body. It's typically done using MRI protocols. And it's typically done using software designed for body composition analysis when you have an MRI. So let's go a little bit more into how DEXA scans are used for body composition. It remains the clinical gold standard of body composition measurements in both pediatric and adult CF populations. Unlike other methods, DEXA can differentiate between lean mass and bone mass. The DEXA procedure is a relatively fast, safe, non-invasive. It emits minimal radiation. It's used for body composition and fat distribution assessment and has been validated against the body composition gold standard methods of CAT scan and MRIs. Okay. So here's a sample DEXA whole body report, kindly sent to me by Sarah Hendricks from the CF Center at Medical University of South Carolina. Thank you so much. When she orders these, she requests a bone mineral density screening and body composition using diagnosis codes for CF, EPI, plus anything else that may be applicable for a bone health-related diagnosis code. The feedback that I've gotten from the listserv and from other centers is that the interpretation of the results for a whole body DEXA scan is not billable, not covered by insurance. So what I learned from Sarah is she applies a formula that can be used to make your own interpretation. For body composition, you can take the fat in grams, the lean mass in grams, the lean mass plus the body mass composition fat from that. And after that, you can, when you derive a fat mass index, you can go to the NHANES data from this article to interpret fat mass index and lean mass index. And I've, in my references, included all these references for you for future. So I used to do tricep skin fold testing until we got our bioelectrical impedance machine, and I used this tool. So tricep skin fold measures really only subcutaneous fat, and it varies between sexes. It can reflect underlying changes in tricep muscle rather than real change in body fat, but it's particularly useful in monitoring changes in fatness in children. So here's just an outline of what I used to do. The equipment I had were the skin fold caliper, a measurement tape, and a marker, a pen and paper for recording, and I would measure the patients, get to the middle part measure between their shoulder and their elbow, mark a midpoint. I would get the mid-upper arm circumference, and then I would also use the tool to pinch the skin, to kind of pull out the skin and pinch it and get a measurement, and I would do that 3 times, and then take the most accurate measurement. And then I would use these formulas to calculate the mid-upper arm muscle area, and then calculate the arm fat area, and then plot that on, I've included the references to look that up for what percentile they would be. A lot of the patients that were like in their 20s, the males wanted to really know about their muscles, so they were interested in doing that, but it's very time-consuming compared to doing that now that I have the bioelectrical machine. It's much better. So onto bioelectrical impedance analysis. The BIA machine applies alternating low-level electric currents throughout the body. It measures the impedance to current flow as it travels through the tissues. The flow of current is affected by the amount of water in the body, so that's really key. Total body water is measured, muscle and fat mass are then calculated, and it takes really less than 2 minutes to do it. It's very quick. So just a little bit of a visual on how it works. The alternating low-level currents allow for direct segmental measurements. The impedance is impacted by the amount of water in the tissue. And the multi-frequency machines are the most accurate because they can really give you a good delineation between intracellular water and extracellular water. There are lots and lots of bioelectrical impedance analysis machines on the market now. Many devices only estimate trunk composition, but the in-body that we have actually measures it. There are other models like the BodyStat, the Tanita. Omron has very inexpensive units. The Sika and the Mediana are also other machines on the market. Many companies have a lower initial price, but will add fees later for software and for monthly use. That was what the in-body rep told me when I asked her why ours was so expensive. I guess with in-body, you're paying a larger amount upfront, but you don't have these monthly fees and things to manage software. This is just a sample of the report that you get from the in-body machine, but I've looked at other machines, and it's a very similar report. So it covers a lot of different topics to go over with the patient. And I'm going to go over each of these a little bit separately on other slides. So for water, for the patient, extracellular water divided by total body water should be about 0.39 to 0.40 for slight inflammation. For total body water, it's comprised of the intercellular water and the extracellular water. Extracellular water can be increased in the setting of inflammation and edema, and also extracellular water can be increased with obesity. The average extracellular water to total body water equals about 3.80 for healthy adults. The range should be about 0.360 to 0.390. There are minor fluctuations that are considered normal, and in pediatrics, total body water increases as lean body mass increases, so muscle has water. If extracellular water increases its inflammation and obesity, it also should be an increase in intracellular water with an increase in fat-free mass. So for muscle, dry lean mass would be the weight of protein and mineral content in the body. So think about dry lean mass as kind of like beef jerky. So it's the bone mineral content and the muscle without the water. Lean body mass, water, plus dry lean mass, all organs, blood, muscle, fat, and fat-free mass. So changes in dry lean mass can be indicative of changes in overall muscle mass. Looking at the muscle fat analysis for the patient, it's the sum of the subcutaneous, visceral, and fat surrounding muscles. The skeletal muscle mass is the overall weight of muscle, similar to dry lean mass and lean bone mass. In the US, they're unable to separate bone mass, but now I'm hearing that some of the machines are able to, on the BIA machines, to look at bone also. Skeletal muscle index would be the appendicular lean mass divided by height in meters squared. It's an indicator of sarcopenia. Skeletal muscle index for males should be less than or equal to 7.0, and females less than or equal to 5.7. I like to talk about this with my patients and draw this for them. There's basic body types that can come from the muscle fat analysis part, and you can see one is a C, one is straight, and one is a D shape. So the C is when fat is greater than the muscle percentiles. It's usually with overweight and obese, also potentially an underweight. The center is just balanced fat and muscle percentiles. Normal weight can still have health risks related to increased fat mass, though. And then the D is what I encourage them to shoot for. It's considered ideal for athletes where the skeletal muscle mass is higher, the body fat mass is lower, and the weight is a little bit lower. So for obesity analysis on this part that I talk about with my patient, it reports BMI and percent body fat. Percent body fat, likely a better indicator of obesity than BMI, obviously, what we've been talking about. And the percent body fat equals the total body fat weight divided by the overall weight. A healthy percent body fat range in adults for men is about 10 to 20%, and women 18 to 28%. And then I also have a little chart here for the ranges in children. So visceral fat area is associated with a lot of metabolic syndromes and cardiovascular disease. It's particularly influenced by cardiovascular exercise. The goal would be less than 100 centimeters squared, and the normal range varies with age, so individuals should aim to remain in the shaded region, which would be under 100 or under. It's really a little bit less clear in pediatrics, but we all know we don't want to have a lot of visceral fat. Whole body phase angle is another interesting area that's measured by the bioelectrical impedance machine. It's the measurement of cell wall integrity and distribution of intracellular and extracellular water. The cell membrane is a poor conductor because of the bilipid layer. So cells with stronger membranes will impede more current flow with a higher phase angle. Lower phase angles are associated with decreased muscle strength, malnutrition, advanced age, some malignancies. So it's really a measure of cell membrane health, and it decreases with disease. Example could be cystic fibrosis. And there's a guideline here for normal phase angle range in adults. Male would be 5 to 7, and female would be 4 to 6. So basal metabolic rate is calculated on the machine for the patient using something called the Cunningham equation, which is based on muscle mass. It's the number of calories needed to maintain basic essential function, and it uses lean body mass, as I said, to measure that. It's not a caloric goal. I have to counsel my patients that they have to add on an activity factor, and especially with CF, I don't really even pay that much attention to it. I like to give them my own goal, but you can see here the different activity levels and what you would multiply by to get that, the caloric goal for the patient. Finally, communicating body composition results to patients. I sort of like to just try to focus on each individual patient, how I feel they are feeling about their body composition, and sort of sense that. I have the athletes that are really highly motivated to build more muscle, but I have other patients that might feel very nervous about having a lot of fat mass. So I individualize it to each patient. Keep it positive. I like to use motivational interviewing, talking about if you can find that one flower in a whole field of weeds, that's what you want to talk about and emphasize. Focus on overall health rather than numbers and appearance or weight. Using that C or D shape to encourage more lean body mass. And like I said, use motivational interviewing and goal setting with the patient. I guess we're going to save questions for later.
Yeah.
Okay, we'll have questions later, but I just want to thank the panel so much for including me in this.
Yeah. Okay, thank you. So now Shannon and Diane have laid the foundation for us a little bit about why you might consider using body composition. And we are going to invite Carla and then Dave are going to walk us through interventions from a dietitian perspective and a physical therapist perspective. But we'll start with Davey coming first. Okay, we'll have Dave coming on up. There you go.
All right, good morning, everybody. I'm excited to be here with you. I'm a CF physical therapist at WVU Medicine in Morgantown, and I'm going to be talking to you about evidence-based exercise interventions for body composition. If I can get this together.
Oh, yeah, use your mouse on the arrow in the bottom.
Thank you.
Mm-hmm.
I have no relationships to disclose. All right, we could talk for hours on this topic, but today we're going to do the 10-minute version. We're going to review an evidence-based approach to performing 3 types of exercise which have been shown in the literature to improve body composition. They are moderate intensity continuous training, resistance training, and high intensity interval training. And then we'll talk a little bit on managing goals and expectations when starting an exercise program. All right, so looking at this picture, I think we'd all agree that despite having the same BMI, these two individuals are not in the same state of physical health. And the difference between the two is their body composition. When we exercise, we are influencing the composition of our bodies for the better. Specifically, exercise impacts body composition in these three ways. We can either increase muscle mass or fat-free mass, we can decrease fat mass, and we can increase bone mineral density. So, looking at moderate intensity continuous training, this is exercise that's performed at moderate intensity for a sustained period of time, also thought of as aerobic exercise. You see examples listed here. The key is to encourage your patients to consider what types of exercise they're interested in, and also that they have access to when considering starting this form of exercise. All right. Using the FIT principle, frequency, intensity, time, and type, the literature suggests these training parameters to achieve improvements in body composition. You'll note there's a fairly large amount of time required to achieve body composition results with this form of exercise. 3 to 5 days per week at 30 to 60 minutes per exercise session. In most studies, running and cycling were used to get the results that were described because these are easier to perform in studies. However, you can certainly substitute different types that works well for your patients, as we talked about earlier. When helping your patients determine what is moderate intensity, you have a lot of options. My preference is if patients have a smartwatch, you can teach them how to use heart rate zones, which would be 2 or 3. You can always help them calculate their heart rate max, but this is difficult for most people. I just use the simple 220 minus age and then multiply it by percentage to give them a range. But if none of these are an option, you can simply use rate of perceived exertion, 4 to 6 out of 10, or the talk test, which is where a patient would be able to speak in full sentences while exercising, but they wouldn't be able to sing without it affecting their voice and their breathing. Resistance training is exercise that utilizes resistance to muscular contraction to increase strength, endurance, and mass. Examples are use of body weight, resistance machines, Olympic or powerlifting, free weights, resistance bands, and again, patient interests and access play a role when choosing the type. These training parameters for resistance training come straight from a great article by Holmes and Granados published in 2022. I would refer you to it if you're interested in resistance training for people with CF. They recommend a frequency of 2 to 3 days per week with intensity of 6 to 12 reps, 3 to 4 sets, 60 to 80% 1 rep max. The hardest part about this is determining 1 rep max, but really it's simpler than you would think. Basically, if you are lifting weight in a 6 to 12 rep range, if your patient is fatiguing on the final 1 to 2 reps or they're breaking form, then you know you're exercising at about 60 to 80% of their 1 rep max. Again, you can see that there's a bit more time required for this form of exercise to get body composition results. However, as we'll see a little bit later, the body comp results are great. Holmes and Granados also recommended in CF full body routines, choosing exercises that recruit large muscle groups which cross multiple joints like squats and chest press, being sure to warm up and cool down. And they also reported no additional benefit with 4 or more sessions per week, 2 or 3 being just fine. Finally, high-intensity interval training is exercise which alternates short periods of high-intensity effort with less intense recovery periods. Example could be sprinting for 30 seconds, followed by a light jog for a minute, and alternating back and forth during your exercise period. Similarly, with a cardio machine, you might row at a high intensity for 1 minute, followed by 2 minutes of rowing at a lower intensity. And there's also a multimodal approach, which incorporates multiple types of exercises, for instance, jumping jacks, squats, weights, and aerobic activities, which you would cycle through. And this type of exercise enables you to incorporate both resistance and aerobic training in one workout. So evidence-based training parameters for HIIT are listed here. I'll point out that the frequency and the time are much less to achieve body composition results than in mixed training and in resistance training. I'd also note that the interval between work and rest can vary based on level of fitness. For instance, a more fit individual could use a 1 to 2 work to rest ratio, whereas someone who's a beginner or is less fit could use a 1 to 4, where, for instance, you may work hard for 30 seconds, followed by light work for 2 minutes, working up to higher intervals as fitness improves. For helping your patients determine what is high intensity, ideally, to get the best result, you want to get as close as you can to 85 to 90% of your heart rate max. So using your heart rate zones, this would be 4 or 5 on the watch. Using talk test, the patient would not be able to speak in full sentences. They would be breathing too hard. Talking would be uncomfortable during this high intensity work phase. So this table briefly summarizes the literature that I looked at for these 3 exercises. You can see that they all improve components of body composition and health metrics. Resistance training is the most effective for increasing fat-free mass, and HIIT is most effective for reducing fat mass. Resistance training and HIIT are a little better than moderate intensity continuous training for increasing bone mineral density. Of the 3, HIIT is the only one that checks all of the boxes, and it carries with it the added benefit of requiring less time. And additionally, Katsalkas et al. Recently found in CF that less dyspnea and less arterial desaturation occurred with this form of exercise, and it produced greater inspiratory and peripheral strength compared to moderate intensity continuous training. A few other notes from the literature. Mode matters. Interestingly, in at least one of the systematic reviews and meta-analyses, they pointed out that for whatever reason, when stationary bike was used, they saw less decrease in fat mass and sometimes bone mineral density. Combining moderate intensity continuous training with resistance training yields better body composition results than either intervention alone. And HIIT offers benefits of MICT and RT with less time is something to consider. We want to encourage meaningful goal setting for our patients, and I'd recommend goals that are either performance-based, body composition-based, or health app or goal-based, rather than, for instance, weight loss, which we commonly think of when we think of exercise. Setting small and achievable goals, especially early on, is very helpful for patients because they can see their progress and it motivates them to continue. And finally, patients will inevitably ask about using exercise for weight loss. And I think the evidence-based answer would be to say that it is possible, but it's difficult to achieve and maintain weight loss through exercise alone. You can see from this figure adapted from Foster Schubert et al. That exercise compared to control did induce a modest decrease in weight percentage, but not nearly as much as diet alone, and certainly not as much as diet and exercise combined. The reason for this is that exercise alone for weight loss primarily relies on creating a negative energy balance, burning more calories than you consume, and it's a lot easier to consume calories than to burn calories. For instance, 1 Snickers bar is 250 calories. You have to jog for 25 minutes at 6 miles per hour or walk for an hour to burn off just that 1 Snickers bar that you ate. So this is not to say that exercise is not useful for weight loss, but it does highlight the benefits of focusing on body composition when exercising, and it especially emphasizes the importance of diet. Which brings us to our next speaker, Carla Nowicki, who will be talking about dietary interventions for body composition.
All right. I'm gonna step a little bit back and a little bit louder than that. My name's Carla Nowicki. I am a dietitian from Columbia, South Carolina. I'm with Prisma Health, and I am actually a sports dietitian turned CF dietitian is my background. So I have a fun background when it comes to especially body composition and our individuals. Use your mouse to click it. Thank you. I have no disclosures for this presentation. And I felt really bad about not having a why slide when it comes to this presentation, because I actually probably have a different point of view than a lot of people when it comes to body composition. And I'm actually very concerned about doing body composition in clinics. I love the idea of doing it for research, but coming from it from a sports perspective, I have seen so many individuals actually get truly obsessed with this number, and it truly almost mimics the exact same thing that we're looking at as this BMI hunt. And this potentially could be BMI 2.0. And I just am concerned of it becoming that, because really when we're thinking about our dietary approach, it is a very habit-based approach. And we're really looking at health at every size. And I want to take that a step further and say health at every shape. I have seen incredible differences in body composition of doing thousands of body composition tests over the years. I have seen incredibly healthy individuals from 11% body fat with females, and I know that's kind of a scary thought, but all the way up to individuals that were 18 and 20% having issues getting pregnant because they didn't have enough fat mass for their body. So this idea of health at every size really plays into body composition at every size as well. And body fat percentage is only one way of defining dietary success. And a lot of the time the individuals are like, oh, I only do it for the ones that are really interested. But a lot of the times those were my red flags all the time in sports, the ones that were always wanting that body composition done. So what does this mean when it comes to actual changes that we're trying to make? It's really hard to separate body fat percentage and body composition away from mass, because really it's just a transfer of mass. And so when we're thinking of these goals all the time, we're thinking of the idea of lose weight, gain weight, or maintain the same. So what does that mean? So if we're trying to gain total body mass, what that looks like of increasing our body composition or improving our body composition, that means we're increasing our muscle mass, and the goal would be to maintain our fat mass. When we're looking at maintaining our actual body mass, that means we're increasing our muscle mass and decreasing our fat mass. But also, most importantly, this is the one we always think about, is when we're trying to lose weight, this means that we are trying to decrease our fat mass, and most importantly, we are trying to maintain that muscle mass as much as possible. And this is that health benefit that we're thinking of when it comes to our lung function, when it comes to CF, because we are trying to keep that muscle mass, and maybe I'm just a little biased when it comes to sports, I love muscle, and muscle mass is so helpful for having that lung function and having the ability to take a step and not break a hip from a fall. So it's not as much that body composition as maintaining that muscle mass. So when I was in my sports nutrition master's degree, my major professor put up this wonderful favorite slide of mine that was like, these are the ways that you can make a dietary impact on your athletes, your individuals. You can make changes to timing, composition, your energy density, the diet composition, not your body composition, diet composition, your energy density, so how much you're giving them calorie-wise, and then also supplementation. Is there anything extra? And I would love to keep it in these beautiful little bento boxes and all clean, but the truth is like when you take one little change of timing, now we've changed basically how much we're eating. We changed our composition because maybe somebody doesn't like protein at breakfast. So it's really hard to separate these, and making sure we're looking at the best part of this. I really did a lot of the focus on meta-analysis because it's really hard to take that all into account. So when we're looking at timing, we're looking at AM eating versus PM eating. This is like loading. So this is individuals that mainly naturally eat in the AM or naturally eat more in the PM. Breakfast eaters versus heavy dinner eaters. And so if you've ever been around CF patients a lot in the hospital, you notice they don't like to get up very early. And there's a lot to say about this, that CF, even genetically, may have more sleep disturbances and delayed sleep-wake phase disorder, which may be actually part of this. And maybe they may be more of those PM eaters. But when looking at what this is, there's actually, they eat about the same amount. There's no difference of caloric density, but there is a very big difference in behavior changes when it comes to AM eaters versus PM eaters. Evening eaters are more likely to eat distracted. They are more likely to eat larger portions at one time. They have more difficulty portion controlling and feel less control of that diet and have really high food cravings and have more stress eating. So it may not be that much of an impact calorie-wise, but that psychological aspect of eating can make a big difference of the timing. So if we're looking at this in a caloric deficit of trying to lose size, it was noted that individuals that were moved into AM eating were able to have a greater total mass loss, but the individuals that actually were more PM kept more of their fat-free mass. So really interesting points with this of being able to maintain that fat-free mass. And I wouldn't be able to go through this without saying anything about intermittent fasting with timing. Not a great idea for CFers. Basically, Trikafta, for one, we can't have fasting windows with Trikafta. The other part of this is the really benefit of it is really shown to be long fasts of 36-hour fasts or longer, not these short little windows. So intermittent fasting, maybe not for this presentation, because also 36 hours of fasting, I don't know anyone that does that doesn't have some disordered eating patterns going on, and I don't really want to promote those. So this is a wonderful meta-analysis done by Darren Willoughby out of Baylor. He's one of the very respected exercise physiologists out of that area. And he made a great looking at, in all of these caloric deficit, different diets, which ones maintained muscle mass the best, which ones actually had more fat mass loss versus kept that lean mass or had least amount of muscle mass lost. So looking at energy density, we're first going to look at this very low calorie diet. And when we think of energy density and very low calorie diets, a lot of this is going to have very restrictive opportunities, and you're going to lose a lot of 25% of that was lost was actually muscle mass. So if we're losing muscle mass, we're losing the ability to have that really good lung function, because that's the key aspect. It's not just about the weight. It's not just about the body composition. It's having that muscle mass. So yes, we see a lot more of if you lose that weight faster, your resting energy expenditure actually goes down. So when we have these yo-yos, now we've lost all that weight and we don't have the muscle mass to bring back. So we have even less muscle mass. And of course, there's a bunch of risks when it comes to not eating enough. So back to the same exact slide we have. When it comes to diet composition, we have low carbohydrate diets, low fat diets, high fiber diets, all having really similar actual effects. So I love fiber, but for body composition, it may not actually be that helpful or effective because we're actually decreasing that muscle mass quite a bit, as well as seeing that 25%. The one thing that really showed to have a really good maintenance of our lean mass was a high protein diet, which you can do a high protein diet and still not decrease the calories coming from your carbohydrates or fat as well. So when we're looking at nitrogen balance, this is a standpoint from the ISSN, the International Society of Sports Nutrition. This is very different than our USDA recommendations. And the major reason for that is thinking through of this is a group of active individuals. Not all of our CFers have issues with their kidneys. But we're looking at the protein balance. If you look at like where you hit from a negative protein balance into a neutral protein balance into a positive nitrogen balance, positive nitrogen balance just means that, okay, we actually have more protein coming in than we're actually expending out. So anything below that, we are losing opportunity for building muscle mass. So if maybe we needed in this 1.4 to 2 kilograms per kilogram range, maybe my individual, I needed 1.65. If I eat 1.5, I'm missing opportunity for gaining lean muscle mass. So really actually being as close to that window of a positive protein balance can be helpful. The next part of this is that statement also says about 300 milligrams of leucine to stimulate muscle growth, and that's about the threshold barrier. Real quick with this, if you have, why it's such a big range of 20 to 40 grams is because if you have 20 grams, that's for more meat-based proteins. Plant-based protein doesn't have a lot of leucine. It takes a lot more protein to stimulate muscle growth. So as far as that goes, supplementation, there's really only 2 supplements that I really want to go through. That is chromium picolate may possibly have a benefit, and EGCG, which is green tea extract. But this is only 1 to 2 kilograms of a benefit. So really, big buck go for dietary changes over supplements. Also, the supplements are the wild, wild west. So if it is not third-party tested, please don't use it. If you are looking what third-party tested means, it just means it's actually on the label of what it is, which these 4 are for testing opportunities for, testing places that do third-party testing. So overall, really focus on habit change, because just knowing your body composition may not actually really help, and it may be very detrimental. Morning bias may prove to be advantageous for behavioral modifications. Intermittent fasting, probably not a good choice. Maybe think about increasing your protein more than what we've thought previously, and then consider supplementation if you really just feel like you really need to take something. And these are my references.
Thank you so much, Carla and Dave. And kind of along the lines of what Carla was saying, these conversations talking about weight, body composition, they are very sensitive, and we certainly want them to be helpful, not harmful. So we're going to have Caitlin come up and talk about the psychological impact of discussing body composition in clinic.
Okay. Down here. Okay, perfect. Good morning. My name is Caitlin, and I'm the adult dietitian in Austin, Texas. Oop. And I have no relationships to disclose. So in this presentation, I will be discussing the literature review on the psychological impact of body composition testing in CF, and I'll be concluding with the best practices in practical application of discussing body composition with our patients. So in starting this literature review, I knew that our nutrition care was shifting from a BMI and weight focus towards the relationship between body composition and health and CF. I specifically wanted to find literature on the psychological impact of body composition, broken down into the subgroups of body image, habits and thoughts towards food, and motives for diet and exercise in CF. While there's plenty of research available about the negative psychological impacts of focusing on BMI and weight in the general population and in CF, there's really only limited research that's been done on the psychological impact of body composition testing for people with CF. Looking at the literature on the history of body image in CF, historically, both males and females have had lower body weight, especially prior to highly effective modulator treatments being available. Therefore, historically, females have had higher perceived body image. This could be due to their preference for being a lower body weight and being thinner. And males have had, lost my point. And males have had males have had lower perceived body image due to their preferences for being larger and more muscular. I think this brings up the question, now post-modulator treatment, how have these body image perceptions changed with weight gain easier to achieve? Also, it's important to mention, when are we discussing body image with patients? There was a study done by Helms et al. In 2017 that found that patients prefer to discuss body image and other psychological concerns outside of physical health concerns, including weight and BMI. Patients reported that it was difficult to discuss body image concerns with their providers when their health goals differed from the health goals of their providers. For example, if a patient was happy with their lower body weight, but they knew that their provider was always going to be discussing weight and pushing weight gain during their visits. With our focus on body composition, I think this brings up the question, when is the right time to be discussing body composition with our patients? Should we be doing that in the context of body composition testing? I don't know, that's something we need to be looking at. Going into body image and body composition testing, there was a study performed by McCluster et al. In 2018, and this study included 212 college students in Georgia, and these participants did not have CF. In this study, they tested the differences in perceived versus measured body composition, social physique anxiety, and appearance satisfaction. The results showed that males had a lower social physique anxiety compared to females and higher levels of appearance satisfaction. There was a difference in appearance satisfaction pre and post body composition testing for females, but not for males. They also found that knowledge of body fat percentage decreased appearance satisfaction scores for females. While this study was only done in the general population, I think it's relevant as our CF population is aging and attending college, and research needs to be done looking at how body composition testing affects body image and body image satisfaction with our patients. Now looking at habits and thoughts towards food, historically many people with CF have not had a positive relationship with food, and many of them, especially some of my patients, have mentioned that they view eating more as a chore, more as a task to gain weight, or they're just eating enough to prevent getting a tube feed placed. Others have negative views towards food due to experiences in their childhood and the healthcare focus of weight and weight gain in CF. Adults with CF may have a more positive relationship with food compared to kids because they have more control over their diet and they've learned from some of those past negative childhood experiences. The strong CF treatment focus on weight and diet may have led some people with CF to have disordered eating habits. This could include restricting or binging certain foods, missing enzymes and or insulin doses, and the misuse of laxatives. There was a study done by Cass et al., which looked at the prevalence of eating disorders in adolescents and young adults with CF, ages 14 to 35. And they found there was a significant number of participants that screened positive for a range of different eating disorders. Now going into body composition testing and thoughts towards food. How will body composition testing affect the habits and thoughts towards food for people with CF? Especially now in a post-modulator treatment area, has our patients' relationship with food changed as they have found weight gain easier to achieve? Research needs to be done looking at how body composition testing affects habits and thoughts towards food for people with CF. I think we need to determine if diet modifications post-body composition testing affect the risk of developing disordered eating habits for our patients. And we also need to determine if we should or should not perform body composition testing on patients who have a history of disordered eating habits. Looking at motives for diet and exercise, historically for people with CF, do we think their motives for diet and exercise were mainly for improvements in health or for improvements in body image? There was a study done by Denford et al. That looked at both the motives and barriers toward exercise for people with CF. Their results found that motives for exercise included introjected or extrinsic motivation, improvements in overall health, and exercising in order to, quote, look normal. They also found that enablers for exercise included enjoyment in the activity, exercising more for means of an escape, and exercising when they have positive role models in their life that also exercise. There was another study done by Dillenhofer et al., which found that physical and environmental barriers played a larger role for preventing exercise for people with CF compared to psychosocial barriers. So that's also important to address. Now looking at body composition testing and motives for diet and exercise. There was a study done by Wadsworth et al., and these participants did not have CF. Their study included 20 women who all had a BMI greater than 30. And with our CF population finding weight gain easier post-modulators, I thought the study might be insightful for our CF population as well. They performed a 10-week exercise intervention and measured body composition. They conducted interviews assessing motivation at baseline, at 12 weeks, and then 6 months post-intervention. At 12 weeks, they found that motivations to continue exercising included exercise and training enjoyment and increased perceived knowledge of exercise. And at the 6-month mark, the motivations to continue exercising included overcoming barriers, exercise competence, and reduced body fat knowledge and results. Therefore, knowledge of body composition results do play a role in motivation to exercise. And research needs to be done in our CF patient population on how body composition testing affects knowledge and motives for diet and exercise. Going into best practices in practical application, I I think we all know that body composition testing is more valuable for health and nutrition outcomes in CF than looking at weight and BMI alone. And our everyday practice needs to be focusing on looking at muscle mass and fat mass instead of focusing on BMI and weight. In my research, I found this quote, and I just wanted to read it to all of you today. The impact of modulators upon body composition and downstream implications for health remain undefined. Looking forward, assessing body composition changes over time may become an important mechanism to monitor therapy and guide treatment decisions in the CF population. And I'd like to add on to this that we also need to be including the psychological impact of this body composition testing. When discussing body composition testing results with our patients, we need to make sure that we include nutrition and exercise interventions that focus on improving muscle mass and strength, and make sure that our patients understand the correlation between body composition testing and their overall health and nutrition status. We need to make sure that the nutrition interventions we recommend promote both intuitive and mindful eating, and we need to assess our patients' relationship with food, especially for our adults. Take into account their past childhood experiences, both the positive and the negative when it comes to food. We need to determine our patient's perceived body image and discuss those concerns in the context of other psychosocial concerns that the patient may face. We need to do more research to determine if there are phrases that we need to use and or avoid when it comes to body composition testing with our patients. It's going to be important to include language that promotes positive body image, intuitive eating, and weight neutral terms. So just some examples of this could include using the term energy versus calories, assessing their growth and progress versus talking about their weight gain, and then using the term gentle nutrition versus a healthy diet. Overall, this literature review concluded that the topic of the psychological impact of body composition testing has not been well researched or addressed in CF. Therefore, that research needs to be done to determine if there is an impact of body composition testing psychologically. We need to look at how body composition testing affects our patient's body image, habits and thoughts towards food, and motives for diet and exercise. And we also need to determine the impact that highly effective modulators have had on body composition, but also the psychological impact of that. All righty, thank you.
Thank you, Caitlin. That was so good. Okay, so we get to hear now from a PT and RD partnership who work really well together at their center in Billings, at the Billings Clinic. And that will be Jacob, who is the RD, and Kelsey, who's a physical therapist, coming up. There it is. Like, where is it? And we'll use the arrow. Please. I would use this one and go down to here. And click on it.
Perfect, thank you. Good morning, my name is Kelsey. I am the physical therapist for the Billings Clinic Pediatric and Adult CF teams. And as mentioned, I'm going to be presenting with my colleague Jake, who is our team's registered dietitian. Oh, I've already messed it up, guys.
You want to use the click that looks like you're right. There you go.
Did I go? No. 10 minutes, and I'm going to spend 5 on this.
Yeah, make sure you're clicking like this button.
Okay, we have nothing to disclose. These are our objectives for today's presentation. All right, when we first began preparing for this presentation, we conducted a literature review to look for evidence regarding PT and RD collaboration in any capacity, not just specific to the CF population. And what we found was that while PT and RD were both mentioned as vital components to a multidisciplinary team, there was not any evidence relating to PT and RD partnership or how to optimize this relationship. Specifically, there was no mention of standards of practice. Despite this lack of evidence, PT and RDs are the two disciplines on the CF team that naturally complement each other and can work towards shared goals. Both our training and professional backgrounds have areas of shared knowledge that can be used to optimize care of the patient with CF, as well as promote body positivity. Lean body mass, bone mineral density, and glucose control are just a few of the more common collaborative topics that we've been asked to discuss and we'll discuss later in greater detail. Because we have this shared knowledge and collaboration, it really helps to keep everyone on the team on the same page. For example, I'm not going to go in and discuss increasing a patient's daily activity without my RD counterpart discussing the nutritional needs to meet these increased caloric needs. And then as an added benefit, when we collaborate, we found that it actually saves the patient some time. When hypothesizing difficulties of collaboration, we thought that clinic structure would be one of the primary ones. We are fortunate at our facility that our clinic is structured to foster a team approach and multidisciplinary collaboration. However, we recognize that this is not the case for everyone. Availability, as not all PTs and RDs are available for every patient encounter, and some clinics don't even have a PT on their team. Time and productivity constraints. I know Jake and I have had to sit down and discuss what these visits were going to look like and how we were going to appropriately bill for them. And then personality, because there is shared knowledge between the two roles and sometimes our goals can be codependent, there might be a difference of opinion and overlapping scope. So Jake and I hypothesized or kind of put together a list of topics that we think has really helped foster a collaborative relationship. And number one is we introduce ourselves as a team. When we go in to meet that patient, we often go in together before breaking up into our respective roles. We talk each other up and try to incorporate each other whenever possible. So as a physical therapist, bone mineral density is something that I'm very comfortable addressing. However, I want my counterpart, Jake, to be in there to discuss some dietary recommendations as well. We communicate very frequently. It's very common for us to be sharing research articles back and forth, and also just having open communication and just asking questions in each other's opinions. And above all, we respect each other. As I mentioned previously, clinic structure is one of the key components that fosters a collaborative relationship, so I wanted to just spend a little bit more time on this. After our patient is roomed, the entire CF team, with the exception of the physician, goes into the visit together, and the goal of this is to have shared knowledge. We first and foremost ask the patient what they would like to discuss during the visit before breaking up into our disciplines and asking some broad questions. And it's really during this time that Jake and I get a feel for the goal of the visit and whether this is something that we'd like to collaborate on or something that would be best addressed individually. It is helpful to kind of keep a running mental list of topics that we like to collaborate on and ones that we prefer to address individually. These here are some of the topics that if we hear a patient wanting to discuss this, it's our cue to just kind of split up into our discipline-specific roles. And then these are some of our more common collaboration topics. If you're looking to get started collaborating with your PT or RD, bone mineral density, body composition, and glucose control might be a good place to start. As a physical therapist, providing exercise prescription and education in these areas is something that we routinely do. However, I wanted to take a moment and just discuss some of the less intuitive ones that Jake and I have just kind of developed over the years. One is sleep. As a physical therapist, I'm happy to discuss yoga, meditations, breathing, and then provide resources. Reflux, especially in infants, I'll discuss positioning both during and after feeding. Headaches, that's my cue to kind of do a postural assessment, look for forward head posturing, but also just to discuss body mechanics at work or at school. Focus and memory, we have a lot of students at our clinic, so I can discuss the evidence behind movement and blood flow and your ability to retain information. And then GI symptoms. As a physical therapist, I'm always happy to instruct parents in abdominal massage or discuss bowel hygiene with patients. And so now I'm going to hand it over to my colleague Jake, who's going to discuss the dietary side of things. Thank you.
Jake. Kelsey's great, right? Okay, she could have carried this further. Left. Okay. So I'm just going to continue on this slide, though. So from just continuing on what she said, so when I cover sleep, We look at, first, are there food combinations that can help the patient that we take in before they go to bed that actually are going to help stimulate the sleep cycle for them or melatonin production, correct? As well as if there's any supplements that can be used. We go over a lot of sleep hygiene. And then we also try to determine, is it falling asleep that's the issue or is it staying asleep that's the issue? So if it's staying asleep, something like the use of tart cherry juice helps keep you asleep. When it comes to reflux, as she also talked about, I jump in with, certainly if it's an infant, do we switch formulas? Do we look at positioning? And then with adults, is it foods that we have to try and work on timing? That type of stuff, as well as use of something like psyllium husk. Let's see, she mentioned headaches. So with headaches, certainly fluids, electrolytes, and then we go from there. Okay, so again, just another look at our approach. So before jumping into the visits, we get our greetings, we talk, we kind of make the patient feel comfortable before we just hop into everything. So we respond to the cues given, ask our questions if they aren't already discussed, as well as if it's actually becomes pertinent to the visit. Because it's not just Kelsey and I that's usually in the room. We have a nurse, we usually have a pharmacy tech. We're able to all go in for the most part. The provider is the main person who stays out of there. And then we focus on the patient's general well-being. We try to remove the pressures of weight and concerns that are regarded to this. Instead, we ask, how do you feel? How's your energy levels? How's sleep? And how do you feel like your strength is? If we do mention weight, it's usually just in response to an inquiry. Like they're the ones asking what's going on with it. And then certainly, we also, as we said, we're peds and adults. So infants, yep, we have to talk about weight, but that's, a little bit different game. So we constantly take readiness level for change into consideration as we're working with patients, as well as their goals. And then we're just trying to encourage them, based on where they're at, to kind of move them towards different levels of change. And then we implant nice messages for the future. And then we're comfortable covering the basics for each other as well as some of the others, just because we have a lot of different reasons that we're out of the office for the day. We do outreach clinics where physical therapy doesn't usually go to that. In fact, I don't know if she's ever gone to that. And so, we're going quite a ways away. And so, a patient, for example, has hip pain. I can do a lot of the questions that she would just to try and investigate of why there's potentially the hip pain. And then, from there, it's get the proper consult into her and she can see them telehealth. So just collaborating through the lifespan. So just kind of a different perspective of all the different groups there. So, we want our patients to be set up for success from the beginning with a strong foundation. So being active together and we want the families to be active together, and we want them to be a whole family and to just overall develop those strong foundations of health, whether it's with food or it's with being active or just being together. And we involve kids in the questions as soon as that they can. We're asking 2-year-olds to give us their input. We involve them as best as we can. And then slowly we start to teach them. Every group, especially our pharmacist, is actually really good at making them tell them their medications. But we ask them, why is that important? Why is it important to you? And why do we focus on those things sometimes? So we try to teach them so that they understand exactly why. And then early adult versus what I call seasoned adults are the approach is certainly different with them because it's like having a kid versus, the parent again in these situations. And so we just manage those differently. So with tackling and optimizing body composition, bone health is, again, just some examples of what we have to use. So we don't have a lot of body mass measuring devices. So our DEXA can't do the stuff that doesn't have the software for measuring the muscle mass. We don't have any cool, awesome machines, so just nutrition focused kind of stuff. I've done way too many of those on people, so pretty good. And then, we use the hand grip stuff just to do that for the fun of it. And then, if we really need to, we'll get out the body fat calipers. I hardly ever use those though. And then just when it comes to bone health, as Kelsey mentioned, we really try to push not just exercise, but physical activity. We're really big in our center on having everyone be active. Montana is a great place to be active. There's everywhere that we can do it. And then obviously, hand in the foods that are going to help out with supporting good bones. When it comes to glucose control, again, we're really trying to get them to be active. We want them to move. Bodies are meant to move. And then just the nutritional based guidelines that will help out with that, balanced type eating, try not to take in, massive amounts and those kind of things. So, and then we really like to also focus on the times of when they're in the hospital. This is a great time. They usually by like day 2 or 3 are ready to really learn something new. And so we really take advantage of the full time that we have with them and just hang out, we talk, and, it's a great time to start, new practices they're ready to change if need be. And then, so again, we just really try to take a comprehensive approach to all of these things. We use the evidence. We also, include the individual and what they're thinking is going to help them out. But it's going to be different for every person that we talk to. Our plan is different every time. And, we just try to, let's see, I follow my notes better, that'd be better. Each patient has, as I said, individualized plan. We incorporate their needs. Our goal at every visit is to build our patients up. That's really important. They got a lot going on. We build them up, build people up. They're great. Y'all are great. So, and Kelsey and I work off of each other's recommendations with the patients and as the needs come up. And so we just try to build that plan that's ideal for them. Some fun patient stories. So, just to kind of give you just a really different view of, we don't get every patient into the gym. It's not many that go to the gym. And plus we're in Montana, so we have weather extremes there. So, we go from, summers can get into the hundreds and hang out there. And then, we do have those nice negative 20s, 30s, 40s, wind chills. It's cold. It snows. And it depends on where you're at in Montana on your weather fluctuations and stuff. So for one patient who is on nocturnal tube feeds, even with Trikafta, still having to maintain being on those tube feeds, providing over 2,000 of her calories every night. We couldn't get her to do any activity for longer than a week. She walked, she would roller skate, she would do all these things, but it just went away due to some reason or another or some stress. We got her VR, and she was pumped for this. And she is no longer on tube feeds. She's eating based off of, she wants to eat during the day off of VR. I was hesitant. I'm like, VR, you guys sure about this? But she's moving. She's up, she's moving. It's really cool. We have a person who is struggling with depression when they weren't active, and so we found them the right activity. It was swimming. Now that they're at college, they're finally ready to be in the gym, and they eat better when they're feeling better. And so we're finding how we're able to get them to just fall into the plan that works for them. We have a lot of athletes, which is really fun. We have runners. We have people. We have someone who does Legree and loves this. Some of the off ones that we have is we have a lot of skiers, snowboarders, and then we have one that's really fun. They snowmobile a lot, so sledding. I don't know if you've been on a snowmobile ever. It takes a lot, and this is a little kid who runs this giant machine. It vibrates a lot. They're really hot, and they go at it for hours, and so we talk about good hydration. We talk about needing to take snack breaks, but then we also work in huff coughs, right? Because they are getting shaken and they're moving around a lot. So we work into what they're doing to keep them active. We're not successful all the time as well. We really try, but we'll take every win that we get. We have one patient that nothing. And then one day he's like, hey, I added in some exercise in between every match of my game. We get to the match is over. I have about 5 minutes before it's time to go in. And we're like, all right, what are you doing? And he's like, I'm using my hand grip squeezers. Thanks. And we're like, yes, we'll take it. We'll take it. Because what came from that was he was more mindful of putting in that effort, and then he actually changed like the stuff that he was doing as well from the food and the drink side. He's like, yeah, I've stopped drinking all the sweet tea now. I'm having a little more water. I'm not ordering DoorDash anymore. So we saw changes just by that one little incorporation. So it was a win, even though it was just some hand grips. It was great. So what to do when you don't have RD or PT? Great recommendations on being able to find a PT by, the article right here lists 4 or 5 different ways where you can actually find like a PT who is CF experienced. And then, we just reach out to those around you, try and meet people. This is a great place, so you can at least get their information, and, we can set up visits one way or another, and then talk them into joining your team. So how to replicate kind of what we do. Certainly this is going to be different with the format and the structure of what you have. And so just really what we try to do is ask how do I fit into this piece and what can I contribute? As we said, think outside of just a typical box. Like for us, we actually have quite a few patients because of our weather during the wintertime. We use VR. They're tiny little towns. They don't have a lot. They don't get to go to a place to walk around because it's like population 5. Those exist there. And so, again, we have a really good team approach for our facility. And so we just get a lot of communication as we go in and as we come out. We always kind of huddle and talk about new things. Let's see. And like I said, always build up your teammates. And then one thing that I've found that, build them up. But when you do that, you put that expectation on that person, you'll find that when you think positively of them, they meet those expectations. The patient knows that person's gonna be great, and they put that pressure on them, and they reach that. So always build them up. Even if you're like, I don't know about this person, talk them up. They'll meet it. And then definitely learn to kind of move past this is how we've always done things. That's all right. We're looking for change. Change is okay. All right. And then we just brought in some testimonials just because there wasn't a lot of standard of practice for this. We just wanted to kind of give an example of some of the other team members. And then we do have a patient who gave a little information. So, given this is from our adult pharmacist, given the obvious relationship between nutrition and physical health, this natural partnership for a dietitian and a physical therapist to work together, they are able to seamlessly piggyback off of each other's ideas to formulate a cohesive, individualized care plan. Pharmacist, right? Those words. Okay, and this is one of our pharmacy techs who's both peds and adult. There's just a natural correlation between the two. They work together to meet the patient's goals while ensuring they are doing so in a way that is both safe and effective. And then this is our pediatric RN. She's in a lot of the visits with us as well, so good seeing what we do. So this approach has been beneficial to the kids in our clinic, talking about making our patients faster in soccer or stronger for bowling. And this kid competitive bowls, he's cool. And all of a sudden we have patients, who are more willing to kind of follow these advice because we attach it to something they're motivated about. And this is one of our patients. He's on oxygen. This is probably one of the best people you could ever run into. So come to Montana, hang out with us for a clinic, you'll meet him. He's on oxygen, like I said, but he's trying to run a half marathon. He's had a lot of setbacks, but he gets closer and closer. Just awesome. And so for him, he wrote a story. So it's good that screen is huge. So it's very encouraging to have people with specific and needed expertise that go to every length to find ways for you to reach your goal. And he adds the biggest benefit of having PTRD together is that it is almost like having a personal training team. They have needed expertise in areas that most of us don't realize the importance of. So they can help us set patients like me up for success when they're aiming for a specific goal. I also think Kelsey and Jake are good together because they are very encouraging. So I can imagine that even for patients that may not be highly motivated, they can work together as a team to help suggest a goal and then come up with ways for the patient they're dealing with. Then, he says PT and RD should be at every clinic. Thank you. And thank you for letting us be here.
Okay, thank you to all of our speakers. So hopefully we're realizing that this is still an emerging topic in both of our fields. I think modulators are adding an entire new level of newness and need for discovery out there. So we intentionally wanted all of our presenters, since we have a diversity of thought and experience, we wanted them all to come up and answer these questions together. Hopefully, probably we're going to get one question might have different answers depending on who we're asking, and hopefully we're going to get some different answers depending on who's responding. So let's. And to you guys, whoever wants to take the first, the question, take it. And if someone else has a different opinion or a different view on that, we want to hear that too. We're hoping we can get lots of different takes and viewpoints on these questions. Is there enough room? Someone could probably come down here. I don't know if you want to come, you could put your chair here. Oh, there's room. Good, great. Do we have a handheld mic in the back? Oh, we'll leave that one. I was just gonna have them pass it, but okay, go ahead.
Okay, thank you for all your questions. There's a lot of really good ones. We're going to start with some basics of BIA. Can you guys give some examples of, if you have one in your clinic, the cost of what it was? Yeah, for the machine, yes.
The in-body that we have is a S10 model, and ran around $15,000, but there's a very huge price range. I mean, there's very simple Omrons that could be $150, and the range I've seen is a lot of them are around $8,000 or $9,000. The more clinical use of machines.
Tell them they can also come to the microphone.
You can also come to the microphone if you have a question as well. Does anyone else have anything to add? Okay. How often are these tests being performed in clinic? And do you give any guidance on the patient's hydration status before you do the test?
I try to get them to empty their bladder before they come, and it's becoming more frequent, but since COVID, we'd had a trend of patients doing a lot more telehealth. So actually getting them in for regular visits to do the body composition analysis has been now increasing. Just now we're coming in more for visits. But as you all know also with nutrition, with the new modulators and Trikafta, a lot of patients don't think they need to come as much for nutrition. So that's been our barrier.
Sorry. When I started doing them, I was doing them at every visit, which was way too much, both for them and for me. Now I do them at everyone's annual assessment, with exceptions. Sometimes I'll do them in 6 months if they get sick and want a new baseline, or if they're really working on exercise, I'll do it at 6 months.
So I used to do a lot of in-body tests, and I had the same S10 model, and I noticed a really big difference when it came to hydration on myself. I could see a 4% difference just by being hydrated versus dehydrated. So having them consistently hydrated makes a really big point when it comes to the in-body, because it is that electrical impedance, and that consistency may be very helpful for you guys.
Awesome, thank you. Okay, so there was questions on, is BIA validated in CF? And on that same note, is the basal metabolic rate accurate?
I don't know about validated. I don't think it's validated. And there have been talks before, not in what I presented today, but prior, that we presented last year, that people recommend a CF specific equation, but that I don't know of any movement on that yet.
Is the BMR accurate, or how do you discuss that in relation to like specific CF patients if they have?
In my opinion, the Cunningham equation and the BMR that I get seems a bit high. So I take it sort of with a grain of salt and do my clinical judgment of calories with the patient.
Okay, pediatrics. When should the first BIA test be performed? What's like the minimum age that you would suggest?
3 years old. 3 years old.
3?
Terry has recommended to start after puberty because fat mass changes a lot. I usually start about 16 just because I don't know. I haven't found it helpful in the younger kids. They're wiggly and they don't care.
Not necessarily a recommendation, it's just what I do.
Yeah. And that's all I had.
I definitely agree with that idea of waiting till 16 because also we are at such a vulnerable age up until that point. So if we are waiting till after we're developing with that puberty, in between puberty and 16, mental health wise is a very vulnerable state when it comes to our body image.
Yeah, I want to clarify, that's what is recommended by the manufacturer for 3 years old. I don't typically do it on young children as well. I wait.
Do you want to go into the fit? So Mike, can you hear me on this? My question about that though with the body image, because I'm very curious about this working in peds, would it be helpful to start it earlier so it's normative versus starting it when we're at a vulnerable age? And you think about this like, sorry, I'm like breathless. I work with burn patients. So the burns that are burned younger, they recover in their body image and their self regulation and how they view themselves is better in younger children because it's normalized or you're starting. So I don't know. I was just curious if anyone had thought about doing it younger. So then it's like it's part of the normal assessment versus now we're looking at it because you've hit puberty or we think there's a problem or do you know what I mean? I don't know. Just curious.
I think it just, can you hear me? I think it just varies patient to patient. I think you need to take into account the whole patient. Some people, it might improve to know their body composition. I think you can't really just pick an age and say this is where we're going to go. It's patient to patient.
I really agree with that patient to patient. Now, I obviously have a very strong bias with this. My personal bias comes from the fact that I was an athlete and I was tested from starting at 12 years old. And my eating disorder started because of having to be incredibly lean. And looking at that body composition number actually is what was the biggest trigger for me because I didn't care about the weight as much as I cared about being the leanest on my team.
Yeah, it's this whole image, like the psychology of it is fascinating to me just because there's so many variables into this. And like we heard somebody talking yesterday in their center, they only were doing it in males. I said, but then we're not getting the information, like if you're using it for an informative thing. We just got a BIA machine, we're not even using it yet, but this is why I think asking the question and just hearing consensus-wise what people think, because there is different ways to look at it. Individualizing, absolutely, and I 100% hear what you're saying. I already know, thinking about our patients, it's like, oh my gosh, I don't want to cause somebody to spiral, just thinking about doing that. But how we use the information, I guess, too, is what we're looking at. I don't know. There's a lot to think about, I guess, more than you think initially, I think.
I don't have a question, but I do have a comment. CF is a small part of what I do. 50% of what I do is eating disorders, and I know a lot of the questions and the things that we're talking about, it's not unknown in the eating disorder world how to proceed with these kinds of conversations. I know there's a big movement to not even weigh children unless it's medically necessary, again, outside of CF. And so I just would put forth, are there like other, experts outside that could share some insight on some of the questions that we're having here?
Also kind of like piggybacking, so I'm an eating disorder specialist. And just kind of like borrowing from that, I just joined the CF world 3 weeks ago. So I'm new. Kaylin is my co-worker. So I kind of like being on my eating disorder lens a little bit. From that perspective, I was just curious. I'm on the PD-CF team. And my question for the field is, can the discussion of body composition, weight, be something that the patient can opt out? I mean, discussing, talking about it. Because I know for the CF guidelines, you need to take those make those assessments, but you have to talk to them. Like, ask the patient, is this something that you want to discuss? Or even showing it to them. Because for eating disorders, we do measure body composition, we do measure weight every week, and sometimes it's something that you just don't have to. You can do it blindly as an option just for us to be, and I tell them like, hey, we're gonna take your weight. We don't have to talk about it, but if something is off, I'll let you know. And we may have the conversation. But I don't know if it's something that it's just kind of like throwing the idea in there. Because it is valuable to get the body composition assessment for sure, but maybe for peds, it's something that I can talk with the parents without the kid in there, so they don't get too hung up on the number. Just throwing it in there.
Yeah, thank you for that input. Appreciating the wide variety of opinions on this. Go ahead, did you want to? We're all over the place, but yeah.
Hi, I'm relatively new, about 2 years in the CF community, and something that I noticed when I came in was how much overlap there is with some of the things we're concerned about clinically in CF, like loss of bone mass, low sex hormone levels, and it seems to overlap a lot with RED-S. And Carla and our physical therapist up here, Dave, I'm curious if you guys have seen that in your clinics, how you address it, and if you change frequency of BIA or DEXA scans or update your calorie and protein requirements, and how you might talk to a patient about that and frame the conversation around treating RED-S if it's a concern.
I am not an expert on RED-S, as I've never heard of RED-S.
So I wrote the protocols for Wingate University's RED-S protocol for their athletes, and which is basically the female athlete triad, but we say it as REDS because that also includes males. This is not all females. A lot of males also have very similar things. And so I have not honestly seen it in our clinic as much as I've seen it outside of our clinic. Again, working in the sports world and looking at, like I said before, of like the span I saw of what I've seen a 11% female U.S. rugby player who wonderful hormone cycles, wonderful relationship with her food, wonderful relationship with her body, just loved to train and was just happy about it. Up to I worked with an individual that truly this idea of her hormones were not even balanced. We look at that range of what's considered healthy. She had struggled getting pregnant, and thinking of our CF individuals, I had a recent patient that had a baby, and she is 86 pounds right now. And she was 96 pounds, I think it was, when she gave birth. So I'm gonna tell you right now, her body fat percentage was really, really low. So that discrepancy of what REDS really could be is so different. And so I don't even wanna say it really being with a body composition as much as we're thinking about it as what is this individual. So that bone density, of course, we're going to see it low in CF, but of course we're going to see it also really low with REDS.
Do you think it is prevalent in CF, or it has?
So we, at least for us, we have a center of adults. I do adults and peds. Our adult center, when I first started, was 20 patients of adults. 5 of those had a diagnosed eating disorder.
For the audience, this is relative energy deficiency syndrome, and it usually occurs in athletes, very frequently in weight-based athletes or endurance athletes who are in a chronic state of undernutrition or specifically low energy availability, and it usually presents late as a increased risk of stress fractures and hypogonadism, and what else was I forgetting? Difficulty gaining weight. Big one is bone mineral density. It's hard to assess, and it's even harder to intervene on because we've seen a lot of studies where people can double their calorie intake and not gain weight. It can take a lot of time to recover from RED-S. And all those symptoms are in cystic fibrosis. So that's why I asked about it.
And my first RED-S was a male soccer player, not a female. So it does happen in men as well, that their testosterone levels are absolutely plummeted by that.
I have a RED-S male, African American, started off at 350 pounds, walking hours and hours and hours a day. He's going to all of these doctors because he can't get an erection, like nothing's functioning correct. And he is not in treatment because he's being congratulated for all of his weight loss. Nobody sees it as a problem.
Hi, my name's Monica Bartlett. I'm from the Riley's Children's Hospital in Allentown, PA. I just want to bring about the BIA. I was really inspired last year about the whole BIA talk. I've been in CF for a long time, and I work in pediatrics. So I went ahead and got the BIA machine, and I've been starting on children as little as 7 years old. And I don't discuss numbers with parents. I discuss a trend. The modulators have impacted their weight, and they're worried because they used to be on 2 feedings and supplements, and I don't have anybody on anything now. It's awesome. It's a great medication. So I talk about trends. So when I see a trend of things moving, especially in their visceral fat, we talk about how they're eating. So my question for you, which I'm not thought about till today, that you brought up about the psychosocial aspect of it. When we have a behavioral specialist part of our team, when do you think it's appropriate to bring that person involved? Early on, or when it becomes like an issue? What should I be looking for? Because I agree, most of them have always felt like, oh, I hate the dietitian. They're always going to talk about pushing food, calories, look at my weight, look at my BMI. And now it's a whole different thing, like you said, that they're actually gaining weight quickly. So how are we impacting these children? Or is this just a new topic, I guess? Early on.
Early on, yeah. If I even suspect anything is like after we do a body comp, I go straight to our social workers, and let them know. Awesome. Even if they weren't planning on seeing them that day, they'll add on and just make sure they're doing all right.
We're just really lucky we have both a social worker and a behavioral specialist on our team. We all work together in one room during the clinic visits. So early on. Okay, thank you.
Okay, guys, we have a couple just like very straightforward technical questions that I want to kind of bing through a couple of those and then get more into the discussion. But I think, oh, no, I lost them. Okay, this might not be technical, but how about what are people doing for patients that have a change in their gender identity? What metrics are you using?
I don't have any, but there was a discussion on the listserv a while ago, which I believe someone said they use their chosen identity. Does someone remember? Or it depended on if they had actually like surgically transitioned yet, and if they were on hormones or not. Yeah.
I asked that question on the listserv. We have a couple that are transitioning and around that age, and so I talked to the social worker, and we actually approached that person because they're not completely transitioned yet, those two patients, and we just explained to them because you have to on the screen in it, you actually have to pick a gender and ask if they were comfortable with that. Both of them said no, so we just skipped it.
Oh. You can skip. You don't have to select a gender.
No, I mean they just didn't want to
Oh, okay. They chose not to. Okay.
I don't know if everyone. Oh. If anyone couldn't hear, she was saying hormone therapy is when they start making that. That's a guess. Her guess. That's her guess. Okay. Let's. So I've also got a question on here. Can people with implants and pacemakers use BIA?
Supposed to use them with metal implants.
Okay. No metal implants.
I have had a bunch of people with continuous glucose monitors, and I've asked because I haven't found anything research regarding if it messes it up. Everyone said it's been their numbers have been fine. Yeah.
Okay. Then a question about the fat-free mass malnutrition parameters. Is that appropriate for the pediatric population, or does that only apply to adults?
I think it was only adults. I believe there were parameters for pediatrics, but there weren't any new studies.
Okay.
So my answer is I don't know.
Mm-hmm. Okay. How about, is there any restriction or limit on water intake prior to BIA measurement? Do they have to not drink?
I never do that.
No.
Just have them empty their bladder.
Oh, okay. They go to the bathroom. We do have a couple questions on just like the collaboration between, sorry, is there anyone at the mic? No. The collaboration on the team. Trying to see which one we could. Okay, so this one of you already answered, somebody already answered how to, if you don't have a PT on your team, does anyone have any recommendations on how to, is there any like published research or benefits to encourage their team to get a physical therapist to join?
Well, I'm biased, so I'm not sure I'm the best one to answer this question. But there are some good resources if you are looking to add a physical therapist to the team. I'm not sure, and maybe someone in this area would be able to answer, but there was a grant going around, and I don't know when they're going to roll it out again. But that's how I first began on the CF team, is it's a grant to support the role of a physical therapist and just to allow them to kind of figure some things out. There's also a wonderful mentor and apprentice program where if you're looking for a therapist to join the team, you can set them up with a mentor in CF who has some experience. And it's just a really great program to allow communication and some experience to kind of get the ball rolling.
Great, thanks. And then there was also more of a technical one, the fit parameters that were recommended. Do those apply to pediatrics, or is that only appropriate for adults?
The majority of the studies that I looked at were in adults, but there were a few in peds. I would be comfortable using those principles with, certainly in teens and younger, they would be certainly fine.
Thanks. And then Jacob specifically, they're asking any recommendations on how to, like, language to use to encourage the dietitian to like work more closely with the PT team. It sounds like at their center, the RD and the GI specialist tag team a lot, but any advice on how to encourage that relationship?
So our GI specialist, she does her own thing, so I don't have to worry about that. But we actually work together quite a lot, but we separate out. I would almost just try and suggest just going into the room just to test it out, sometime, or even throw PT in with the RD and GI, just to see how it, if they enjoy it, if there's anything that they can learn from it. I mean, like I said, our cohesion is going to be different than everyone else's, but just try it out. I mean, that's the only way you're going to know. Try it either with just the two of them or combine all sorts of combinations.
Thank you. Go ahead.
Thank you. Very well rounded. Appreciate all your opinions and different aspects. So I'm a dad of daughters. Both have CF. One is 6, one is 10. So literally last week, my oldest said, "Am I too skinny?" So question is positive framing. I think, Jake, your team does this, and Caitlin, is it? The psychology of the words you use. So I brought my notebook. So you say energy versus calories. What else do you have so I can take home and use this week?
That is so cute.
There is a weight neutral talk tomorrow morning also, which might be helpful.
I can give you some recommendations.
Thank you.
Yeah.
Yeah, come to the talk tomorrow. Yeah. How about that? And well, hold on.
If anybody was at the RD Social Work Consortium, that weight inclusive Google Drive also has a lot of different, you're nodding your head, a lot of good places to look and start. But I have something specifically for parents too.
Okay, thank you. Very good question. Okay, so these are some dietary questions for Carla. If a patient increases their protein intake but does not change their physical activity or maybe doesn't exercise, would that have a negative impact on their weight?
So as far as negative impact on weight when it comes to protein intake, there's actually a lot of showing that even if you increase your protein intake far above what you can actually use for developing muscle mass, you actually will not change your actual overall size and mass. So you will actually, as a healthy, not as kidney issue individual, you will just naturally discard that. Your kidneys are really amazing. So you can actually increase your protein a lot more without having any damage. And at the same side of that, if they're not increasing their weight, there's actually, if you change that composition of just higher protein, you actually might be keeping the same weight but decreasing muscle mass and increasing muscle mass, decreasing fat mass just by changing that composition in your diet and not even changing your exercise, because you actually needed that protein all along and you weren't getting it.
Do you guys have any recommendations on assessing the rate of fat mass loss or the rate of lean mass gain as a metric for success and safety?
I haven't seen anything on that. I've seen it takes about 12 weeks to gain about a pound of muscle, but that's just on average. That's not like a recommended rate of anything.
I have seen very different amounts of muscle mass gain, but if you think about weightlifting, you first start when you start lifting weights, for example. The first 6 weeks is all neurological, not all, but mainly neurological. Once you're hitting past that, you're actually starting to see that muscle gain. If the person's already lifting a decent amount, you can definitely, I've seen quite a bit higher increase in muscle mass within even 2-3 weeks if the person's already trained. So if they're detrained, I could definitely see that, but more trained individuals could potentially gain more muscle mass pretty quickly.
Hello, I'm Sarah. I work at Vanderbilt, which is in Nashville, which is in the South. So we have a lot of, I will say, improving diet quality is definitely something that we have to do as a familial approach. My physical therapist had to step out, but in terms of like the high protein diet, so a lot of times my dietary interventions, I tend to just choose one thing that the whole family can utilize, whether that's, decreasing soda intake, increasing vegetable intake. And so I often use either a combination of my plate or the Harvard plate method. So just in terms like a visual aspect, like what would you recommend kind of using that to be a high protein meal or a high protein diet, just to make it a little bit more, because I can envision it in my head as a dietitian, but how would you translate that to clinical practice?
Yeah, so I love the plate aspect, but I draw my own plates because it's so different for each person. So I take a circle all the time, or I have a whiteboard in every single room that I draw on constantly. And so what that ends up being a lot of the time, it really isn't that much. I mean, 3 ounces of chicken breast, that's 20 grams of protein right there. And that's like the size of your cell phone. I mean, this isn't a ton of protein that we're talking about volume wise. And that's what I talk about is the idea of volume. So it's usually, I would say, thirds lean protein, vegetable, starch. But sometimes it ends up being for the more active, half that plate ends up being carbs, a quarter is vegetables, and a quarter is lean protein. It's not a lot of volume with a general plate still. And I definitely talk about that.
Okay, thanks. We're going to do a little shift to get an exercise question in here, probably maybe our last one. So this one was the ratio of exercise to rest and HIIT. I found that heart rate doesn't come down as quickly for patients with poor cardiovascular pulmonary status. I feel it's important to get adequate rest between, then maintain the ratio. What are your guys' thoughts on maintaining that ratio on people with poor CVP status?
Certainly, that's a good point. If you were trying to do 40% of your heart rate max for your rest period, you could start out at 40% to determine what setting or what level of intensity that feels like before going up, so you would know to go back down to that feel. And you could also increase your intervals if you're needing more rest, your work to rest intervals. Those are my first thoughts.
Okay, last question. What are your thoughts about creatine supplementation?
Use some creatine. Creatine's awesome. I'm pro creatine.
Go ahead.
Oh, sorry.
Yeah,
Yeah.
just to get some more voices.
Yeah, sorry.
You can go too.
Use it. It helps with bone mineral density in studies, so use it for that, and it's awesome. So there's
Concussion protocols. We use it a lot in sports as decreased risk for concussions is a big one, and maintaining power muscle fibers in elderly.
How much?
3 to 5. 3 to 5 grams. It can be used in kids.
Do you take it ongoing?
Ongoing. Yep.
The same dose?
Same dose.
What about like the loading dose? Like I usually tell them not to do a loading dose.
You don't have to. It builds up within, with the 3 to 4 weeks.
Is there a dietary equivalent?
Isn't it like 400 grams of beef or something like that?
Yeah.
Yeah, it's like 2 kilos or something of beef. It's quite a lot.
Is that before exercise or after?
Whenever. Yeah. It's also good for memory. It's being shown right now to have effects with reducing risk of Alzheimer's. Like, use creatine.
What age?
Shoot, I think 5 I've had kids start it.
When will they be consistent?
Neuromuscular, it gets started pretty early with them.
Why is consistency important?
Because you do have to take it every day for it to load up in your system. So that consistency aspect is incredibly helpful of making sure, like if they'll take their vitamins every day, that might be trustworthy enough to do it.
Do you have a recommendation for brands? I asked that because I had an adult patient who developed acute renal failure after starting creatine supplements, and it improved after he stopped it. So the only assumption we could make was that he was using some creatine supplement at the end of the day.
Which ones you got?
Thorn is my favorite. It's what the U.S. Olympic teams usually also use, if that tells you how safe it is.
All Max is mine.
Okay, I think that's all the questions we have time for today, but thank you for the really robust conversations and thoughtful questions, everybody. And thank you to our presenters, all the work that you guys did leading into this.